Very good day to all of you and warm greetings. Today's topic is all about myocardial infarction. In short, it's called as MI, and we are going to see about the pathophysiology, that is the manner and the development of MI. So our main objectives that we are going to discuss and talk about here is definition, then etiology, that is what things will cause MI. Then we have pathogenesis, which means the mechanism of development of MI. Then we have to talk about location of MI, where and all it will occur in the myocardium or in the walls of the heart. Then we need to discuss about the compensatory mechanisms or the responses after the MI has caused. And finally, we would be discussing about the morphological changes that happens in terms of both gross as well as histological perspective about the place where the MI has occurred, and finally ends up with complications of MI. So, myocardial infarction is defined as, in layman's language, it is defined as heart attack, and it is nothing but the death of cardiac muscles that is due to prolonged severe ischemia. Hope ischemia has been talked about by the previous lecture, and ischemia is nothing but a condition where there is an inadequate supply of blood and oxygen to the myocardium. So, the muscles will lack the nutrition to survive. Myocardial infarction is also defined as a discrete focus of ischemic necrosis. And what is meant by necrosis here? So, necrosis is nothing but an irreversible cell death. That means the muscles die because of some lethal injury, and following that there might be some changes also takes place in the infarcted area. So, that would also be coming under the topic of necrosis. So, here is a picture you could see, and in an inset you would see a vessel. That vessel is being blocked or occluded or thickened, and the area distal to that does not get blood. So, the area which is marked in this picture or demarcated here is the area where the myocardial infarction has taken place. Now, let us move on to the next objective, that is etiology, that is the causes which will lead to myocardial infarction. So, there are various multifactorial risk factors which will predispose to myocardial infarction. So, usually we classify them as constitutional risk factors and modifiable risk factors. In constitutional risk factors, the age is one factor. So, it increases the chances of getting MI if the age is getting older. That means the vessels will all get blocked in the elderly age group. Then comes to the gender. Men are more prone to get an MI when compared with women till their menopause, till the age of 50 years. After then we see that men and women are equally have the chances of getting MI. Then in family history, if anyone in the family had MI due to their constitutional factors, then the person have more chances of getting an MI. Then woman in the reproductive age group, suppose if she is taking oral contraceptives, it is seen that they have an higher chances of getting an MI. Race, of course, non-Caucasians have more chances of getting MI when compared with Caucasians. Coming to the modifiable risk factors, the increased blood pressure and increased blood lipid levels have high chances of causing MI in an earlier times. Also smoking. People who are smoking heavily have high chances of getting MI. Now, there are people who suffer from high glycemic values. So, they are called as diabetes mellitus. So, they have 2 to 3-fold greater chances of getting MI when compared with non-diabetic individuals. Now, people who are obese, they are more likely to have dyslipidemic levels also. So, their chances are also seen 2 to 2.5-fold increased risk of ischemic heart disease. People who have a sedentary lifestyle, of course, they also have higher chances of getting MI. So, their regular exercises will definitely shown that it reduces the chances of getting MI. So, now moving on to the next objective, that is to identify or to understand where and all the MI could come in the heart. So, the location of MI is being talked about in relation to the coronary artery supplied. So, what are coronary arteries? They are the main arteries which supply the nutrition, the blood and the oxygen to the heart. So, they mostly arise from the aorta, and you could see that there are two vessels here, one here and the other one here. So, this one is the left main coronary artery and this one is the right coronary artery. This left coronary artery branches into two, and we have the one coming like this is called the left anterior descending artery. This usually supplies the blood to the anterior aspect of the left ventricle and also the 2/3 of the interventricular septum, and most of the apex part is supplied by this particular vessel. Okay. Then you have another vessel which is branching from the left main coronary artery, that is left circumflex artery. So, this actually covers the left lateral side of the ventricle, and it takes a curve, goes backwards also, and gives the posterior side of the ventricle. Here the right side occupies in majority the right ventricular wall, as well goes back, and it gives one other main vessel called as posterior descending artery. So, this posterior descending artery is one vessel. If it rises from the right side, then we call them as a dominant vessel 2. So, the same thing, the vessels which supplies the area of the heart is being just been spoken with the diagram. This is a flow chart which gives an exact classification of the vessels supplying the heart. So, this fact I would like to tell you here is that the posterior descending artery, wherever it arises from, either it is from the right coronary artery or it is from the left coronary artery, that particular main artery will be called as a dominant vessel. So, around 90% of the individuals usually get this posterior descending artery from the right coronary artery. So, based on this overview of the arterial supply, we could easily identify the place where the myocardial infarction has taken place. Suppose if the left anterior descending artery is occluded or blocked, we would see that the infarctions would be in the anterior wall of the left ventricle, the apex of the heart, as well the anterior 2/3 of the interventricular septum would be affected. Suppose if the LCX, that is the left circumflex artery, is affected, we would see the infarction would be in the left ventricular lateral wall as well to some extent in the posterior side of the left ventricle. Suppose if the right coronary artery block has happened, so the right ventricle is mostly affected as well, since it gives the posterior descending artery, the posterior wall of the right ventricle as well the 1/3 interventricular septum will also be affected due to this particular coronary artery block. Okay. This picture gives you an idea about how an intensity of the infarction would have taken place. See in this first picture, so because of the vessel occlusion, there is an entire wall of the heart is affected. We call this infarction as transmural infarction. Suppose if it has affected only the subendocardial area and only a very minor part of the wall, then we call this as regional subendocardial infarct. If it has completely circumferentially affected, we call it a circumferential subendocardial infarction. And if it is micro infarcts at various places of the heart wall, then we call this as multifocal micro infarction of the heart. Now moving on to the main objective, that is the pathogenesis, that is the mechanism of development of the myocardial infarction. So the most commonest mechanism that involves to cause a MI is arthrothrombosis. Okay. So the vessel is occluded by thrombus. So we need to know what is meant by thrombosis and thrombus. Thrombosis is a formation of blood clot in an inappropriate manner and it doesn't dissolve, and so the vessel is completely occluded after the triggering mechanism has happened. So because of that, the vessel is completely blocked. So the blood clot is called as thrombus. Okay. So because of the gradual or sudden occlusion of the blood vessel, the myocardium will undergo ischemia and the muscles will become dysfunctional, and prolonged vascular compromise will end up finally in a myocyte death. So here if you see how this thrombus or thrombosis process has taken place. In this picture you could see a normal blood vessel, the wall is all thin and the lumen is well spacious, actually the caliber is all well maintained. Whereas here you could see a thickened wall with something filling in the area of the blood vessel. So this entire area we call it as atherosclerosis. Hope in the previous lecture it is being explained to you what is meant by atherosclerosis. So this is gradual thickening of the blood vessel and narrowing down the space of the vessel would lead to a compromise in the supply of blood to that particular area of the myocardium. So this is a process which usually takes years. As we keep older, the process keep continuing and become worsen also. Okay. So at times what happens when there is any rupture or a fissure is formed, or sometimes any the blood hemorrhage is formed inside due to some rupture of the vasorum of the coronary vessels. All this will expose the contents, that is these contents, to the blood, and these contents will immediately provoke a clotting mechanism. So that is what will happen usually. So when the internal content is exposed, like the collagen or the necrotic contents, immediately the platelets will start to adhere to each other and they will get activated, and the granules of the platelets will be released, and that will initiate a process called a microthrombi. So, after the microthrombi is formed, you would be seeing that various other mediators also start to play the role, and one other factor from the subendothelial area, that is called tissue factor, will be activating the coagulation cascade. So, this will add up the bulk of the thrombus. So, the platelet as well as the coagulation end products like fibrins will cause a huge thrombus formation. So, after the thrombus completely occludes the vessel lumen, you would see that there will be a severe ischemia to the distal area of that particular vessel's myocardium, and around 20 to 40 minutes of this occlusion will cause an irreversible damage and myocyte death. So, that ends up with the myocardial infarction. So, this entire mechanism constitutes around 90% of the causes for myocardial infarction. So, another 10% if you see, the myocardial infarction is due to some other reason, not due to thrombus formation. Okay. So, what are they? They are, the first one is vasospasm, that is the vessels will be very severely constricted. Usually it happens in certain drug injections like cocaine and ephedrine, and also some unknown platelet aggregation can also lead to vasospasm. Then emboli. Emboli is one substance which is moving inside the blood. Mostly it could be a thrombus from some other place, not from the coronary vessels. It can be from some other place, and it can go into the coronary vessels and occlude the vessel also, can lead to MI. Then other rare causes which leads to MI are people who have a disease called vasculitis. That means inflammation of the blood vessels. So, inflammation of the coronary vessels can also lead to MI. Then you have certain conditions called sickle cell disease, where the normal RBC, instead there might be sickle cells in that place, will occlude the blood vessels. They will clog and it will cause occlusion. So, people who are suffering from an abnormal protein secretion called as amyloid, if it deposits in the vessel, can also lead to the occlusion of the blood vessel by thickening of the wall. That is also possibly can lead to MI. Then marked hypertrophy. In times the hypertrophy of the ventricular wall can cause an aortic stenosis. So, the blood that has to get supplied into the coronary vessels would be compromised, and that might also sometimes lead to myocardial infarction. Then at times, sometimes the blood pressure will be so low, it will lead to a condition called shock. There are different types of shock like hypovolemic shock, cardiogenic shock, septic shock, like that. So, in any kind of shock, blood supplying the heart might be compromised, and that will end up in myocardial infarction. And very rare chances surgical injury can lead to MI also. So, these are all the entire mechanism which actually develops MI. So, 90% is due to thrombus formation, only the 10% would be other causes which will lead to MI. Now, once the MI has taken place, this is the next objective that we have to see about, is the compensatory responses that usually takes place. So, we classify these compensatory responses. Some changes would take place after MI. So, we classify them as three phases. One is called inflammatory phase, then the second one is the proliferative phase, and the third one is the maturation phase. So, inflammatory phase, as soon as the myocardial infarction has taken place and the muscles have undergone death, we would be seeing that the necrotic debris will invite the inflammatory cells in that place. So, the first of it would be the neutrophils and the monocytes will start to infiltrate in the place where the myocardial infarction has taken place. Okay. So, the area will be completely being mediated by the inflammatory cytokines as well. Okay. Now, after some hours or after some days passed, this inflammatory phase will be slowly shifting into the proliferative phase. So, in proliferative phase, if you see, the muscles once dead will not be replaced or will not be regenerated. Instead, it has to be replaced by some fibrous tissue only. So, what happens is there will be myofibroblast proliferations will start to increase in those times. So, the collagens will all deposit in that place and extracellular matrix will pack them and keep the wall intact, but the muscles is not there to contract. So, this phase is called as the proliferative phase. So, the inflammation will be resolved there and it will all be replaced by the fibrous tissue. So, at this time, if you see, the infarcted area will be very hypokinetic and dyskinetic, and it will not able to contract the actual blood that is required for the body to receive. So, what happens? There will be a reduced cardiac output. So, this cardiac output once reduced, there will be an activation of neurohormonal mechanism. So, that means the blood that goes to the kidney will be reduced, and that will activate a cascade called as renin-angiotensin-aldosterone mechanism. So, the aldosterones, the angiotensins, the norepinephrine are all secreted, and what happens is that will prevent the excess water or excess volume being lost. So, volume will be restored and more blood will start to come into the heart. So, the more the blood comes, you would see that the sclerosed and fibrotic heart will be slowly keeps dilating. So, the dilation will increase and the heart will undergo a failure. That means the heart cannot contract completely to push the blood to the organs. So, that stage is called as the failure stage. So, in the maturation phase, what happens is the fibroblasts will undergo some quiescence, that is old aging, and the fibrous areas will all be getting dilated and it will finally end up in an heart failure. So, this is called as the congestive heart failure. The blood will be stagnating and keep stagnating in the other organs also. So, these are the entire mechanism of compensatory responses that takes place after the myocardial infarction. Now, moving on to the morphological changes that usually takes place in the heart. So, we are going to talk in terms of two aspects. One is the gross changes, the other one is the histological changes, that is the microscopic changes. Okay. As soon as the myocardial infarction has taken place, in the early hours, we generally do not see any changes in the heart. But after some hours, that after some 4 to 12 hours, we would be starting to see some dark mottling. So, in this picture, you are able to see some dark mottling or the dark areas where the infarct has taken place. So, in the end of the day and after some few days have passed, these dark areas keep changing its color, and finally, you would see some amount of grey yellow or grey tan yellow in color of the area where the infarction has taken place. This picture also shows rupture of the heart that has taken place here, and after some a week's or 2 weeks time, you would be able to see that the granulation tissue have started to come in that place, that is fibrous tissue has started to come in that place, and in the end of 2 months or after 2 months, we would be seeing complete fibrous structure in the place where the myocardial infarction has taken place. So, this is what the picture is showing. So, the entire wall which has undergone myocardial infarction is showing a grey white area. This is called the scar, and this is indicates that this is an old infarct. That means the infarct that has taken place 2 months before or some months before it has taken place. Here is another picture that you could see that if you able to dissect the heart after MI, and if you immerse them in a chemical called as triphenyl tetrazolium salt, you would able to see a brick red stain in a non-infarcted area, whereas in the infarcted area this does not stain. So, this way you can also identify the infarcted area of the myocardium. So, this is actually happens because the infarcted muscles will lose the enzyme called lactate dehydrogenase, and because of that it does not have a reaction with the triphenyl tetrazolium salt reaction. So, coming to the histological changes that usually takes place after the myocardial infarction. Here in the initial hours, generally we do not see any changes in the microscopy, light microscopy, but there are few changes that you could see them in electron microscopy. So, there will be some mitochondrial changes, some clumping and margination of the chromatin, etc. and all. But after some 12 hours to 1 day, the muscles which underwent MI will become deep eosinophilic, and the neutrophils will all start to infiltrate in that place. And in the end of the day to some 2 or 3 days, you will see that the necrosis is well established. You will see the nucleus undergoing pycnotic changes, that means pinpointed structures. Then it will start to fragment sometimes, it is called karyorrhexis, and sometimes it gets lysed also. The sarcomeres, that is the internal channels will all be elongated, and the membranes will all degenerate at that place. And the phagocytic process will start to take place by means of the macrophage cells in the end of 7 days. And finally, the fibrosis process will be evident in the slides that you see after 7 days of myocardial infarction. So, they are called as fibrovascular granulation tissue formation, and slowly the neutrophils will decline and the fibroblast cells will increase with more of collagen deposition and the extracellular matrix substances. Finally, if you see in the 8 weeks or 2 months and more than 2 months, you would see that a considerable dense fibrous tissue is formed in the place where the myocardial infarction has taken place. The same things which I told you now is being depicted in the pictures that is shown in this slide. So, this is the early hours. You could see the more eosinophilia of the myocytes, and the inflammatory cells are all started to infiltrate in these areas, and the infarcted muscles show some wavy structures, whereas the normal non-infarcted areas are all straight in nature. Here you could see that a very dense neutrophilic infiltrate has started to infiltrate in the area where the infarction has taken place. And in the days to come, and after a week's time to 10 days, the neutrophilic infiltrate is all absent here, and the infarcted muscles are started to get disintegrated and phagocytosed by the macrophage cells, and new fibrous tissue, that is the granulation tissue, has started to come in these places with more of increased neovascular structures. And this picture you could see very clearly that very few residual muscles here and there are present, and more predominantly these fibrous tissues are present in the old scar area of the myocardial infarction. This is another way, this is called markers of myocardial necrosis. This is another way how clinically they diagnose myocardial infarction. There are certain markers which are there to identify whether infarction has taken place or not. So, we have some 3 major markers. These are all the proteins that are there inside the muscle, and when the myocyte death takes place, they obviously would come out of the cells. So, we have myoglobin, which is one of the proteins. We have certain enzymes, creatinine kinase myocardium enzyme. Then you have some other proteins called troponins T and I. So, myoglobin would be the earliest one which is appearing in the blood in the first hour itself, peaks at around 4 to 12 hours and goes to normal in 1 day itself. So, this is not that so specific. Of course, in the first day you can identify infarction using this myoglobin, but these two things, CKMB and troponins, if you see, it usually appears in the 4 to 9 hours and peaks in 1 day and stays 3 days. So, more than that, the troponin T and I stays for 7 to 14 days. So, this will be more useful. Even after 3 days of infarction, you can identify whether that person has gone in for infarction or not. So, this is the last slide that I am going to discuss about. It is called the complications of myocardial infarction. So, you all know if the necrosis of muscles take place, the muscles do not contract well. It is called dyskinesia or hypokinesia would be there. So, the impaired contractility obviously will lead to more stagnation of blood in the ventricular chamber that will end up in that will end up in mural thrombus formation. This mural thrombus will be throwing out some thrombi emboli or some emboli would be thrown up to other organs, and it can cause a stroke or it can cause a another kidney ischemia, etc. can take place. Sometimes the hypokinesia will be so severe, so the heart would be not pumping well, so that will end up in hypotension and cardiogenic shock. Sometimes the stagnation of the blood will lead to a congestive cardiac failure also. And if the infarction is so extensive, the entire wall is affected, the transmural infarctions might end up in a rupture. So, that is called as the ventricular wall rupture, and the blood will ooze into the pericardial sac, and that will cause a cardiac tamponade. And suppose if the infarction has taken place in the areas of where the conduction system works, so you would see that there will be arrhythmias because of the electrical instability. And one thing you have to note here is 80 to 90% of sudden cardiac death is due to arrhythmias, especially due to ventricular fibrillation. And finally, sometimes during the infarction, the inflammatory cells are invited in that place. So, that might also lead to the pericardial inflammation also, ending up in pericarditis. So, these are my references. Hope you enjoyed this session, and thank you very much.